Believe it or not, this is the first center in the world of its kind. And the conclusion is by the docs that they are not independent. You know, often a neuro issue will lead to a cardio issue and vice versa. And the other thing is, if you add the vascular system, which connects the two, it represents about 70% is a number I remember being told of sort of all the medical issues that that individuals have. So it's clearly the most important part of our body. So that's why we were putting them together. Why haven't other organizations done it, and why St. Mike's? You've got to have, I think, the reason it hasn't happened in other organizations is because most medical hospitals are very siloed. You work in a department and you think and you research in that department. You need an organization that has a very different culture, and that's the culture at St. Mike's. It is one that dates back to sort of the 1890s. It's a culture of teamwork. It's a culture of excellence. It's a culture of innovation, all centered around patient care. And that is a very unique combination. And I think why those of us like myself are so proud to be part of this organization. It is such a unique place. So what are the keys to success? What do we need to do to achieve this? Well, first of all, you need world-class docs. And, you know, at St. Mike's, that's where you have to start. So St. Mike's is the home to some of the world's foremost neuro and cardiovascular surgeons. Our cardiac team has a history of pioneering life-saving heart procedures. You might be interested to know that Canada's first heart transplant occurred at St. Mike's. Our neurosurgery department is one of the largest and most specialized in North America, and we perform more aneurysms and brain tumor procedures than anywhere else in Canada. You need an organization willing to look at healthcare differently. And a key part of that to me is the research side of our organization. We are really become a force in, I call it applied research in the country, and you'll hear a little bit more of that from Ori. We need to innovate and embrace technology as part of that, artificial intelligence, and take best-in-class techniques. It's never good enough at St. Mike's. We need to do better. We have people who are the best in the world at what they do, and they want to continue to lead. Again, Ori may talk about it, but one of our initiatives, which is part of BRAIN&HEART, is to be sort of the leading medical AI applied team in the world, and today we are, and you're going to hear more about that. And the concept at St. Mike's, this is a layman's term, as I often say, we want to focus on treating the patient, not just the medical issue, which again leads to sort of the team concept. And so how can you help us? From my lens, you know, Toronto, Ontario, and St. Mike's are better off and better served if we can attract and retain the very best brain and heart specialists in the world. And that requires innovation, which includes state-of-the-art technology, leading AI, which I talked about, and approaching the patient from a holistic and not just a silo perspective requires investment. And again, I'm going to tell you where we're at on that right in just a moment. To me, the result will be an incredible leading change in healthcare, which will result in dramatically improved patient outcomes, not only at St. Mike's, but across Canada and maybe around the week, could potentially dramatically reduce. And through research, I think a better understanding of the causes behind some of these diseases, because they're going to be looked at holistically. The good news here is we're well on our way to create the world's first brain-heart center, thanks to an incredibly generous $19.125 million donation by Walter and Maria Schroeder, just incredible philanthropists. We've raised $33 million to date of our target of $42 million goal. So we are well down the road here. As a volunteer, board member and donor, I personally am inspired by the excellence and innovation that I see every day at St. Mike's. We are a well-kept secret, and we're trying to make it less well-kept. We have a vision of changing healthcare that is happening at St. Mike's, and we need you to consider helping us finish the project. The leading care for patients with brain-heart issues will redefine patient care in the future, which is an extraordinary goal. So with that, I'm going to now set up the real people who are going to talk to you here. You're going to hear from Dr. Mark Peterson, who's the medical director of the Brain-Heart Center. He will give you a behind-the-scenes look into why it's unique and what we're up to. You'll also learn about why we're building a state-of-the-art facility that will revolutionize. You asked Dr. Ori Rothstein, who is Vice President of Research and Innovation, to share a few words and introduce Dr. Peterson. And I'll pass it over to Ori.
Okay, so thank you very much, Mike, and welcome everybody. I think it's great to get you all together to talk a little bit about something that is really important to me, and I think to all of us here at St. Michael's Hospital. I see a number of familiar faces there, but and good to see you again, but those of you who I haven't met before, so welcome, really happy to join in today. So really what we're here today to talk about is the Walter and Maria Schroeder Brain and Heart Center. And I think the focus of the discussion will be from Mark Peterson, who is currently the director of that center. And he'll give really some, I think, specific details. But what I'd like to do is just focus and highlight three areas over the next couple of minutes that might be of interest to you and are very relevant. First of all, I want to talk a little bit about COVID and the impact that COVID has had on research and innovation here at St. Michael's Hospital. Then talk a little bit in very broad introductory terms about where we are today with respect to the Brain-Heart Initiative and where we're going. And then finally, I have the privilege of being able to introduce Mark. So first of all, let's talk a little bit about COVID and the effect of COVID on research. I think, you know, obviously, things have changed a lot around COVID. That's really an understatement. And I think that, you know, our hospital systems changed remarkably with COVID. And, you know, we had to pivot and do things that we weren't anticipating doing. We had to do it quickly and we had to do it effectively. And I think that, you know, three very good examples of that are, you know, first is that our COVID assessment center was up and running within 2 weeks of being requested by the government to do it. And now we're one of the highest volume places in the GTA. Second, I think you'll know that the Gilgan Tower was not scheduled to open until much later, but because of COVID, we actually were able to open several of the intensive care unit beds in the Gilgan Center in order for us to care for patients who had COVID at the time. And then I think finally, and quite importantly, you know, our scientists and our faculty here at St. Michael's Hospital really stepped up to look after vulnerable members of our downtown population, particularly those experiencing homelessness. And so we did all those things very quickly, and it was really important to do so. Just reflecting on research a little bit, I remember the day of the shutdown very well. It was March the 18th. And on that day, we had to tell our scientists all to go home. We couldn't do any experiments. We couldn't have our students or our scientists, even in the institution, they had to go home. At that day, in St. Michael's Hospital at the Keenan Research Center in the Li Ka-shing, we were doing zero research on COVID, zero. Not one scientist or graduate student was doing any research on COVID. So remarkably, like the hospital, the scientists pivoted very quickly, and they applied their intellect, their skill, and their brawn to address the COVID pandemic. And so today we have about 100 COVID projects going on across the Research Institute at St. Michael's Hospital. They range all the way from research at the very fundamental levels, where we're looking at how the virus basically interacts with the cells in the lung to cause severe lung injury, which is a hallmark of the disease. We have research that looks at how to best ventilate patients who have made it into our intensive care unit basically related to their severe lung injury. We have one of our scientists leading a global trial on blood thinning and how you can use blood thinning to prevent the downstream consequences of having COVID disease, because we know that it causes clotting of the blood. And then finally, our scientists have been working extremely hard to look at how they can address some of the health inequities that actually were magnified by the COVID pandemic. I have to say, it was a little bit dizzying, but we were up to the task. Our scientists at St. Michael's Hospital successfully competed for over $10 million in research funding from national networks. This is the highest of all the hospitals across the University of Toronto. Our donors also stepped up and gave more than $10 million towards our COVID funds, the Courage Fund and also the Power Fund. And that includes about $1 million for research. And many of you are familiar that we even morphed our highly successful Angel's Den competition to be totally online. And this year, I think we attracted over 2,000 people to watch our online presentation. It was really remarkable. And we actually gave out about $500,000 in prizes. So from these really important lessons that we learned, it was actually an opportunity to go forward. And it's really has acted as a little bit of a catalyst for the researchers, but I think not only the researchers, but also the leadership of the institution. And I think that it aligned very well with what we wanted to do in our strategic plan, was to provide the best care experience for our patients. And that was really the rationale for showing some new leadership that was now a little bit more bold than we thought. So my second objective is to tell you a little bit about how we're already at the forefront of this thinking by talking about an area of innovation, and in particular, the Brain and Heart Initiative. So even months before we actually had the COVID pandemic dominating the landscape, our Brain and Heart leaders were already reimagining and reinventing the care experience. And this aligns again with our patient care experience focus. Simply stated, this group conceptualized and really started to implement paradigm-changing models of care. The expectation was that the work would revolutionize care and for our patients at St. Michael's, but also before that, because the leading edge work that we're doing will not only be relevant for people here at St. Michael's, but also locally, nationally, and internationally. And that's where we see we're going to be. And I think that we've had to change our models. Like I said, like Mike said to us, traditionally, specialists like cardiologists, cardiovascular surgeons, neurologists, neurosurgeons, radiologists, each work on different floors, on different things within their own silos. They rarely work together. But actually what was pretty clear to us is that, you know, the brain and the heart and vascular diseases are really not separate diseases, and that care would be very best delivered by having really a collaborative initiative such as the Brain and Heart. The common diseases of the heart, such as heart attacks involve hardening of the arteries, ruptured aneurysms in the brain are due to changes in the vascularity, and even diseases like Alzheimer's and certain forms of dementia are known to have a genetic link and be related to basically vascular disease. So with that rationale in mind, our specialists started to work together. Our cardiologists and our surgeons joined forces in the operating room, and cardiac catheterization, which used to take place outside the operating room, very quickly moved in because we saw that the cardiologists and the cardiovascular surgeons had to work together. Similarly, our radiologists and our neurosurgeons started to work together because instead of doing basically operations on the brain, we could access those blood vessels in the brain by actually just going through the arteries up to those small blood vessels. And so overall, our neurosurgeons, our radiologists, and our cardiologists and cardiovascular surgeons are now sharing their systems and doing best practice. So with this practice and approach, we saw huge advances in surgical techniques. 20 years ago, I hate to say it, when I started my practice, if you needed your aortic valve replaced, you had to have a general anesthetic putting you totally asleep. You had to have a massive incision in your chest wall. You had to stay in the intensive care unit for 3 to 4 to 5 days. And if you were lucky, you got out of hospital in 7 to 14 days. Today, our teams do it very quickly through putting a small tube or a catheter into the groin under minimal anesthesia, meaning with just local anesthesia. And usually those patients can get their heart valve replaced and go home the next day. With this considerable progress, I mean, we really thought we were on our way, but really, we're really just at the very front end of this overall project. And I think, the brain and heart has become a linchpin for our hospital strategic plan to bring together our major programs and innovate in specialized care. So it also brought together other areas where there are actually 3 high-profile types of work going on. Many of you have heard of the surgical black box. One of our surgeons, Dr. Theodore Grantrov, actually has aligned together videotaping everything that goes on in the operating room with artificial intelligence to better understand how operations are done, where errors occur in operations, how you can identify errors and prevent them from occurring before they actually occur. Second, I think you know Mohammed Mamdani, and Mike talked to this, is really the first vice president of data science and advanced analytics at any hospital in Canada. And he's done really world-breaking research already to harness the power of artificial intelligence to bring together artificial intelligence, big data, and advanced analytics really into healthcare, but more importantly, right to the bedside. And these approaches will be applied specifically to the Brain and Heart Center to improve our diagnostic accuracy, to improve our prognostication, and to actually assess treatment choices for our patients. We're already using this in a very sophisticated way to predict strokes in our patients. And finally, St. Michael's Hospital Leakage Knowledge Institute and the Kino Research Center have become global powerhouses in basic science and clinical research. Our bench-to-bedside approach is unique and is really our secret to our success. And let me give you a few examples of those. I think that, first of all, we have cardiologists and basic scientists, researchers working together. Kim Connolly and Michael Kutrick are learning how you can take stem cells from the body and put it into patients to help heal the heart. Our chief of cardiology, Dr. Howard Leong Toy, is actually using non-invasive techniques such as ultrasound in order to improve gene delivery into the heart. And of course, we have one of the largest aortic valve collaboratives in Canada and approaching that in the world with surgeons like Dr. Mark Peterson and cardiologist Dr. Neil Pham at the cutting edge of innovation in our innovative procedures. So within the next decade, I think it's safe to say that how patients experience in the Walter Experience Care and the Walter and Miriam Schroeder Brain and Heart Center will not be an afterthought, but it'll actually be the leading edge care here at St. Michael's and broadly across the world. So finally, my third task is to introduce Dr. Mark Peterson, who's, I think he won't show you very many gory pictures because he probably doesn't make gory pictures anymore. But I know Mark very well. I was actually the surgeon-in-chief at St. Michael's Hospital and take some responsibility and maybe credit for recruiting Mark to St. Michael's Hospital. Bob Howard helped me, Elaine Metrick helped me. We brought Mark to St. Michael's Hospital. And in my role as surgeon-in-chief, my job was to build a department made up of surgeons who would make a difference, world beaters. In our field, these are individuals who provide absolutely top-tier clinical care. So they're the very best surgeons, ones that people go from all over the place to get looked after for. But in addition, those individuals were selected because we knew that they would be able to propel their field forward by doing groundbreaking research and innovation. And Dr. Mark Peterson is really one such individual. We brought him here to be a surgeon innovator, not only somebody who looks after the most serious and complex cardiovascular problems, but also somebody who can really change the way that we do business. I'm very pleased to introduce Mark Peterson to you. He's not only a really gifted surgeon, but also a visionary leader who, with his colleagues, really has developed these plans to change the way we approach cardiovascular neurological disease in the Walter and Maria Schroeder Brain and Heart Center. So Mark, over to you. Looking forward to your talk. And no gory pictures, please.
Well, thanks very much, Ori and Mike. I think you've basically covered the essence of the brain and heart as well or better than I could have. So hopefully I can sort of complement the essence of what you both said in order to bring to life in pictures some of the things that you've already alluded to so well. I appreciate everybody's donating their time generously to hear kind of some of the exciting things that are going on at St. Michael's Hospital. So what I want to do over the next 30 minutes or so is I really want to take you on a bit of a journey from where we've been, where we are at present, and importantly, where we're going. And although we're going to focus a lot on technology and we're going to focus a lot on techniques, really the essence of why we've put together the people that drive the Brain and Heart Center together really focuses more on the people, the innovation, the ingenuity, and the collaboration. And technology is really an enabler for us to help treat patients in better and more less invasive ways. But ultimately, it's the people that at St. Michael's Hospital which are unique and that are driving this forward. So I'm going to just quickly, some people refer to evolution of healthcare from kind of old school healthcare, which is often referred to as healthcare 1.0, which is really the kind of old school style of medicine, really a very doctor focused approach where patients are seen in decentralized clinics, single doctor, single patient interaction, which really has many limitations to particularly today with access to care teams, such as the care teams that we put together in the Brain and Heart Center. And really health, I won't spend a lot of time on this, but healthcare 1.0, the sort of the past way of doing things has really evolved to what many people describe as healthcare 2.0, which is kind of how we find ourselves today. And towards the end of the presentation, I'm going to show you what we believe is the version of healthcare 3.0. And healthcare 2.0 was really quantified or qualified by increasing specialization among many specialties in medicine, a very processed, focused approach to medicine, which led to incredible discovery and improvements in individual specialties with a focus on quality control and making operations better than they had been in the remote past. But it did have some negative offshoots, which really led to specialists becoming very narrow in scope and working in silos. And so we believe that to move forward into the new era of medicine, that we need to break down these silos and bring specialists that have not worked together in the past working under the same roof in the same location using similar tools, all for the benefit of the patient experience. So I'm going to show you this because I want to just spend the first few minutes really establishing what the baseline state is, so that as we move forward into some of the newer things we're doing, and as we look towards the future, we have an understanding of kind of where we are and where we're going. So here's an example of the modern, this is actually the blueprint of the operating room at St. Michael's Hospital. And this is a very common state of affairs in most major hospitals around the world, whereby the surgical specialists, like heart surgery, you see rooms 1, 2, and 3, these are the cardiovascular surgery rooms, are aligned around a group of operating rooms with other specialists like plastics and ortho, neurosurgery, general surgery, ophthalmology, orthopedic surgery, for example. There's many benefits to this organizational structure. These specialists, they share commonalities in terms of the requirements for a sterile place to operate. They share instruments. There's some basic OR nursing expertise that's required. But what I hope to show you, and one of the reasons we're moving towards the Brain and Heart Center as a new way of doing things, is that cardiovascular surgery, though it shares some of the equipment issues that some of the other fields use, over time there's been such increasing specialization that what cardiac surgery and ophthalmology, for example, or cardiac surgery and orthopedic surgery, they don't have much in common anymore. And this old school of organization isn't working to optimize patient care, innovation, discovery, and it's not an optimal environment to do the kinds of operations that I'm going to show you. So just keep this in mind when we refer back to the future state. So I was happy to see that Mike Norris alluded to one of the pioneering heart surgeons at St. Michael's Hospital. This is a picture of Claire Baker in the 1960s. He was an outstanding clinical surgeon, and in his time and in his way was an unbelievable innovator at St. Michael's Hospital. He performed the first successful heart transplant in Canada in 1968, a year after Dr. Barnard performed the first human heart transplant in South Africa, and was a pioneer in the sort of golden era of cardiac surgery. There's many, I'd like to think that I have many similarities with Dr. Baker. I don't think I have quite as much hair on my chest as he did, but we're practicing in a different environment. So perhaps a safer environment. But the golden era of cardiac surgery. So just to, I'm going to spell out the job roles, and the reason I'm going to spell them out is that the roles of the jobs of the doctors, for example, are changing over time. So I was trained classically as a heart surgeon, which meant that, for the most part, when I was training, really the type of operations that we were suited to do were to open patients' chests while they're asleep, to get access to the heart and stop their heart, and then perform operations on an arrested heart. And sorry, I should have said there's the disclaimer that there will be a few gory pictures, so but they're relatively PG. So in the heart surgery actually first started in the late 1800s, but it really didn't get going until the 1950s with the advent of the heart-lung machine. You can see in the picture on the right here some of the tubes that allow us to put somebody on what's called cardiopulmonary bypass, or the heart-lung machine, allows heart surgeons to stop the heart and operate on an arrested, bloodless field. And that allowed a tremendous amount of innovation in the types of operations that could be done. So this is an example of a patient who's had their heart stopped to replace their aortic valve in a conventional, traditional way. It's a patient who had a valve repair operation, and this is a patient who had a bypass operation. And so really the golden era of cardiac surgeries was upon us in the 50s. And cardiac surgery in this state is still going strong, but you're going to see that that due to the impact of new techniques and new technology, we're now starting to get away from some of these big open-chested operations. So here's an example of a patient who has, in the middle panel, has a large aneurysm of their aortic root. This just showing the measurements here. And this patient, unfortunately, in today's, in the way we understand things today, that with the knowledge and the expertise we have today, we still would have to do this patient with a big open heart operation. The innovation in those type of operations over the last few decades have gone from having to replace a patient's valve. That patient with the aneurysm has a normally functioning valve, but in the past, that valve would have been replaced with a mechanical valve, which means that the patient has to be on a blood thinner for the rest of their life. And it means that the patient's lifespan is now limited compared to somebody who had their own aortic valve. And so part of the innovation that happened throughout the golden era of heart surgery was to make these operations better, to find new ways of doing these operations, still done through an open chest procedure. But you can see that this patient now has a tube graft replacing their big dilated aorta, and their own valve is reimplanted into this graft. So the innovation here was going away from mechanical valve replacement to valve repair when possible. This is just a video from the operating room. And the reason I'm showing you this video is I want you to understand what open cardiac surgery looks like. Because although we still do this, and in the many settings we still need to do this, we're going away from these big operations where we open the chest, we stop the heart, we put them on bypass. This is a patient with a big aortic root aneurysm that we operated on recently. And so rather than replace their valve, we're using this graft here to basically sew their own valve back inside of this graft. And basically what this is called a valve sparing root replacement. So these operations have gotten very good. And if you look at the results, and again, I'm showing you the slide because we're going to come back to this in the later part of the presentation so that we understand why brain and heart is so important. In the days of Dr. Baker, it was a huge deal to get a patient out of a heart operation alive. But over the last 30, 40 years, there's been so many advances in anesthesia, in surgical techniques, in perfusion techniques, that we've done these operations on over 100 patients with a death rate of 0, a low stroke rate, very low risk of bleeding, low transfusion rates, and a fairly limited hospital stay. So in order to move the needle for our patient care, at least those that still need open operations, we need to start focusing on other endpoints other than just survival. If you have a heart surgery center where the survival is, or the mortality for heart operations is high, you're probably not going to be doing heart surgery for very long. And so I'm going to come back to this later in the slide presentation to help us understand why the brain and heart is so important to move the needle in certain areas of the things that we do. The golden era of cardiac surgery, I believe, is probably past. We are now entering an era where big open operations, they're not shunned upon, but when it's the only option, we still do it. But we're starting to move into an era where there are other options. There are a number of reasons why we're innovating. We're innovating because technology is allowing us to. We're innovating because we're finding new ways to put doctors together and care teams together. But also, if you look at this slide here, so one of the big operations that heart surgeons do is coronary bypass surgery. You can see that the gray bars, there's really been very little growth in coronary bypass surgery. In fact, if you extend this out to 2020, these bars are going down. Whereby angioplasty, where cardiologists, interventional cardiologists can access the patient's heart and arteries to open them up without opening the chest, these procedures are on the rise. So there's a lot of pressure to innovate and pressure to make things better for our patients. We're moving away from big open operations towards more minimally invasive operations, either done through small incisions with the advent of wires, catheters, and depending on the type of operation we're doing, either stent grafts or novel valves that we can replace the heart valves with. I'm going to show you that in a minute. So what we're undergoing now, what's part of sort of healthcare 2.0, if you will, is this really revolution from, you know, a cardiovascular surgeon who comes to the operating room every day and simply opens chests and stops hearts, to someone who has a blended skill set of open operative skills combined with wire-based, minimally invasive skills that are directed by some form of imaging, whether it's fluoroscopy, which allows us to visualize the wires and the arteries, or ultrasound imaging, or CT, MRI guided imaging. We're undergoing this transformation from surgeon with one skill set to really a structural heart disease specialist. So I'm going to start now talking a little bit about some of the innovations in transcatheter valve technology. So Dr. Rothstein referred to earlier sort of cardiac surgeons and cardiologists coming together. I realize I'm focusing on the heart side, but I will get back to the brain side in a minute, and I'm going to explain how the two of them work together. But cardiologists are sort of the medical equivalent of heart surgeons. The cardiologists don't go to the operating room and operate on patients. They're the ones who, there's various branches of cardiology. Here's a picture of a French cardiologist who invented the transcatheter heart valve operation back in 2002. Cardiologists, particularly the interventional cardiologists, they access the heart not through open incisions, but through wires and using catheters. And so in the siloed version of healthcare 2.0, the surgeons would work in the operating room and the cardiologists would work in what we call the Cath lab, or the catheterization lab. But in order to integrate disruptive technology like the one I'm about to show you, it's forced us to start working together. And we've realized that by working together, we can actually do a lot more than either of us could do working on our own. So here's another pioneer, Dr. Bob Chisholm. He's an interventional cardiologist at St. Michael's Hospital. He was actually inspired to go into cardiology by Dr. Baker, the surgeon from the 60s, and studied under Dr. Baker and some of Dr. Baker's colleagues. And Dr. Chisholm and I started our transcatheter heart valve program together in 2009. So this was a huge leap forward in the way we did business on the heart side of things, because in the past, let's be honest, the heart surgeons and the cardiologists didn't actually get along all that well. And to be honest with you, they competed for the same patients. The surgeons were convincing the patients to have open heart surgery because it was a proven, durable option that had good evidence. And the cardiologists were trying to convince patients to have minimally invasive procedures because they didn't have to have their chest cracked open. But we decided, you know, we're going to start doing these operations together. So this was really the first time that a surgeon and a cardiologist got together to do to do a procedure together, to join forces, if you will. So back in 2009, when we started the transcatheter heart valve program, we didn't actually have a purpose-built place to do this. You really need the best of the operating room and the best of the imaging lab or the Cath lab to do this properly, but we didn't have that in 2009. So this is a picture of the old Cath labs at St. Michael's Hospital in 2009. You can see the X-ray equipment. This is not an operating room. We converted it into an operating room by bringing up some of the equipment from the operating room. This is one of our OR nurses. And we formed a super team. We converted the Cath lab into kind of a de novo hybrid operating room. And so this is a picture from our first transcatheter aortic valve replacement, where Dr. Chisholm and I, and obviously a very big team, did our first transcatheter aortic valve replacement at St. Michael's Hospital. We eventually built, with the assistance of generous donors like yourselves, we built a purpose-built, Dr. Rothstein and Eileen Metrick, the former head of the foundation, allowed us to raise money and convert within the operating room core. We were able to build a purpose-built hybrid operating room. So those activities moved down to the operating room, where we could combine the best of both worlds, the best of a sterile operating room environment and all of the things needed if the minimally invasive procedure were to go offline and require conversion open surgery. this could all be done here, where you can see the ceiling mounted X-ray equipment to help us visualize these transcatheter heart valves. So what am I referring to? What's a transcatheter heart valve? Well, just to remind you, replacing a human being's aortic valve, which is one of the most commonly diseased valves in the human body, it controls blood flow between the left ventricle, the main pumping chamber of the heart, and the aorta. This valve becomes calcified with age, becomes very narrowed. It impedes blood flow from the heart, and patients start getting short of breath, chest pain, they can pass out, and eventually they can die. Once you've got severe aortic stenosis, the condition shown here, you're going to die within 5 years. And so in the old way of doing things, and to some degree we still do this today, we still put patients on bypass and open their heart and open their chest and replace their valve with a cow or a pig valve. The new way of doing things, the transcatheter valve way of doing things, is to access, for the most part, in 90% of cases, we access the patient's groin with the patient awake. We put wires and catheters into their blood vessels, and we go backwards into the heart. And these specially designed valves, which can be collapsed in a delivery system, can be delivered via the arteries back to the heart. And under a period of rapid pacing to just temporarily stop blood from the heart, we can blow up a balloon and we can replace somebody's heart valve literally in about 20 seconds. I mean, the total operation from start to finish takes about 20 to 30 minutes, but the actual replacement of the valve takes about 5 to 10 seconds. So this is just showing kind of how disruptive this technology has been. The gray bars are the standard conventional open chested aortic valve replacement. And you can see that they've been sort of flat since 2009 when we started the transcatheter aortic valve replacement program. And they're actually now on the decline. Whereas back in 2009, when we started the program, we did 20. That's incorrect. We did 20 our first year. And there's been a pretty much an exponential growth to the point where this year we're projecting around 225 to 250 transcatheter heart valve replacements. So we're actually doing more catheter-based heart valve replacements today than we're doing open-chested, surgical aortic valve replacements. So that program's really formed the sort of initial coming together of a surgeon and a cardiologist. It's now involved multiple surgeons, multiple cardiologists. The team has grown to involve imaging specialists, nursing specialists, research specialists. It's become an enormous team and a huge program. In fact, we've renamed the transcatheter aortic valve replacement program the structural heart program. And the reason for that is that by putting that program together, it allowed us to start replacing other valves of the heart and the same valve in different ways. So here's an example of a patient who's had heart surgery in the past. This patient's 84 years old, suffering severe shortness of breath. And this is an echo image showing that the valve is flopping backwards. So this patient is quite short of breath. Their valve is leaking severely. This color flow shows that the valve is leaking severely. So what are the options for an 84-year-old patient who's had prior heart surgery, who's frail? Well, one option would be to say that the patient's too old and too sick to have any kind of operation, and we'd manage them with medicine. Of course, their quality of life won't change, and their chance of dying within a year is high. We could offer them a very high-risk redo heart operation and replace the aortic, and in fact, the mitral valve was leaky as well. Or potentially in the paradigm of our new emerging structural heart program, perhaps we can offer them a novel transcatheter heart valve replacement. So this is a valve that's not yet approved. This valve is designed specifically to treat patients with leaky heart valves. So that those 220, 225 patients that I showed you that we're now treating every year, most of those patients have narrowed heart valves. But this technology has taken off, and some centers around the world are innovating the technology that we were able to get access to a device. We were one of the first centers in the world to use this particular technology to allow us to treat this. Animation probably will show you how this works, just to give you an idea what catheter-based heart procedures are like.
The delivery device by advancing both
so we access the patient's femoral artery, we put a wire across the aortic valve and into the patient's heart, and this allows us to, this device sort of self-orients within the patient's aortic valve. And once the valve is oriented, now the reason why this valve was purpose-built for patients with leaky valves, the patients with the really narrow stenotic valves, the device as it's expanded has something to hold on to, but the leaky valves, there's nothing to hold on to. So this device was designed to capture the leaflets and to allow the valve to start working right away in ways that we couldn't do before. So I'm just going to quickly take you through kind of the procedure we did. This just shows a patient's aorta. We're injecting dye into the aortic root. It shows that the valve is leaky. And then we've established access in the groin. We put a wire into the heart. And this is just showing how this self-orienting device orients down on that diseased leaky heart valve. And then we can deploy the valve through a series of highly engineered knobs on the device. We image the valve, and then this is sort of the final picture whereby we demonstrate that the valve is no longer leaking. So really, this technology allows us to do this patient awake without putting them to sleep in ways that we couldn't do, whereas this patient would have either died with a leaky valve or had a very high risk redo operation with the chance of dying that would be quite high with traditional surgery. So, as we developed our structural heart program, we started to bring more and more people into it. We started forming alliances with industry because we had a reputation for being very innovative, for having a very well worked out system of care for patients from A to Z, with really good collaboration between myself, the surgical side, and the cardiologist. Here's a picture of Dr. Neil Pham, who's an interventional cardiologist, very innovative. He's my co-lead in the structural heart program. And so this team gave us this team concept, this emerging merging of the specialists allowed us to get access to devices and to help develop devices that could be applied to treat patients that had valve problems of other heart valves. So we were the first center in the world to treat patients with one of the other valves in the heart called the tricuspid valve. Patients with leaky tricuspid valves are a big clinical challenge for heart surgeons, very sick patients, very difficult operations, and also the patients often didn't do well after a standard open chest tricuspid valve replacement. So we helped develop a valve with the company that was applicable for a transcatheter tricuspid valve replacement. This is just a picture of the team after the first of its kind in the world. And so we did a study. There were 6 institutions around the world. We did 8 of the first 25 patients and led the study. And down here, you can see, sorry, I'll just go back 2 slides. So down here, this is an example of a valve that doesn't look anything like a traditional surgical valve. This is what we call a transcatheter tricuspid valve. It actually looks like a flying saucer. It can be crimped down into this highly complex, highly engineered delivery system, again, to allow us to replace other valves in the heart through a catheter-based system. So here's a CAT scan. Part of this growing care team involves advanced imaging and radiologists. We have an excellent partner in Dr. Diva, who is a cardiac imaging specialist. So we put patients through a variety of tests. This is a CAT scan showing the heart. You can see that the right heart here, the chamber in white, and the right atrium are hugely dilated, much more so than the left side. This side should be quite small. We use this imaging to help plan these catheter-based operations. And here's just a series of panels kind of showing how we would, in the first iteration of this device, we actually did it through a small incision in the chest wall, but we now have moved on to doing this through the groin again. We use imaging in the hybrid operating room, as well as echocardiography to help guide placement of this valve. So again, we're not opening the patient's chest, we're not cutting the valve out, we're using sophisticated imaging techniques and a highly engineered and designed device to kind of deploy it in sequences as we capture the native tricuspid valve. And at the end of the day, what you see here is a tricuspid valve that's been replaced through the groin. We're injecting dye into the patient's heart, and you can see that there's really no residual leaking. If we had done this test before the valve was replaced, you'd see all this dark dye refluxing into the right atrium, but you don't see that. And you see in these other panels, the echo, this is a three-dimensional echo picture showing the valve working well. And the pictures in the lower panel here show that there's no leaking across the valve. I'm going to kind of go over this quickly. This slide really just summarizes that this expanded new heart team of surgeons and cardiologists working together have allowed us to do replace heart valves through small incisions in the neck. We're the first team in North America to do this, one of the first in the world. We're able to replace the mitral valve, another valve in the heart, using a combined approach through the groin. And we were one of the first centers in Canada, in the world actually, to replace the mitral valve using a specially engineered transcatheter mitral valve system. So just a brief summary of some of the things. And this is kind of the milestones in our program from when Dr. Chisholm and I started the structural heart, well, we called it the transcatheter aortic valve program, which has morphed into this very complex structural heart program. So back in 2014, we did one of the fifth in the world of a transcatheter mitral valve. There's 4 major valves in the heart. We've replaced all of the major valves in the heart using catheter-based technology. This was an example in 2018. We were the first place in the world to replace the tricuspid valve using the Evoke tricuspid system, and a number of other sort of milestones in our program. So to sort of graphically represent this paradigm shift, we really have surgeons that no longer work in silos. We have interventional cardiologists who don't work in silos. Really, we're coming together, and really what we do now, we spend a good part of our time, rather than working apart, working together. And although I focused on the heart, the same is true for my colleagues in vascular surgery who operate on the blood vessels, and their corollary in interventional radiology who do procedures on the blood vessels using wires and catheters. And the same can be said for my colleagues in neurosurgery and neurointerventional radiology. We have 3 surgical fields merging with 3 interventional fields. The overlap is what we're doing now, and I think the opportunity is to merge those circles so that we don't speak of open operations anymore, that all of what we do is really one and the same, that we create a future hybrid blended specialist. So just to give you a quick flavor of what's happening on the brain side, very similar to the heart side, in order to treat a patient's aneurysm in the brain, so little outpouchings from the blood vessels which can rupture and cause bleeding in the brain or death. The neurosurgeons, my colleagues in neurosurgery, used to have to open the brain in order to get access, again, done asleep. But they've invented, or technology has been developed to allow access to aneurysms in the brain through the vascular system, similar to the way we access the blood vessel system and on the heart side of things. And so here's just a schematic of an endovascular treatment of a cerebral aneurysm. So rather than opening the skull and getting direct access to the brain, we're accessing the brain through these wires and catheters to coil the aneurysm. Again, these can be done on patients, and patients can go home in a day or two rather than being in a neurotrauma ICU or on a neurosurgical ward for several weeks. And just to show you how real this technology is, the surgical treatment of brain aneurysms in blue has declined over the last 10, 15 years, whereas the coiling of aneurysms, or the endovascular treatment of aneurysms, has become really the de facto way of treating brain aneurysms. So why do we need a brain and heart center? I mean, we're doing a lot of this stuff already. Well, there's as most of you know, there's often a huge resistance to innovation and technology. And so the technology which has been introduced by the surgeon or the cardiologist affects the care pathway of the patient from the time that they're seen in a clinic scenario through their actual procedure and through their follow-up care. And in healthcare 2.0, we haven't established a milieu or an environment to allow this to be done in a seamless, effective, best practice kind of way. So by creating a center or a program where new technology, innovation, creating these super teams is the basic DNA of the institute or of the center, we're really changing the entire way we approach patients right from the first interaction, rather than that kind of single doctor, single patient interaction, which you saw in the first few slides. We're now creating an environment where patients come to disease-based, highly complex, disease-based clinics where they see a surgeon, they see an interventionalist, they see a number of people outside, not just doctors, they see nurse practitioners, physiotherapists, they see people that are involved in advanced research studies. And in order to do this, we've had to completely reorganize how we work and where we work. But there's another reason which I've alluded to in the presentation as to why it's important to bring specialists who haven't worked together in the past together in one place. So I like to use this example because it really illustrates the principle as well. So here's a patient, and it all comes back to how we improve care for our patients. Here's an example of a patient who had a stab wound to the neck. And what you see here, this is an angiogram which shows the artery in the neck and the arteries of the brain. So this outpouching here is basically where the stab wound has led to bleeding out of the patient's carotid artery. It was felt at the time that the neurosurgeons or the vascular surgeons could not access that part of the carotid artery because it was too high near the skull base. So a neurointerventionalist, vascular and cardiac surgeon, and a cardiologist all got together on the fly and invented a solution. Well, how did they do that? Well, at the time, there was no such a thing as a covered stent. So they basically invented the world's first covered stent to treat a problem like this. A stent is basically a scaffold or a frame, but in order to stop bleeding out here, you can't just have an open cell frame. So a vascular cardiac surgeon took a piece of vein from the leg, they took an off-the-shelf open cell stent on the back table, sewed this together to make a covered stent, and implanted this into the patient's carotid artery using minimally invasive sort of image-guided endovascular techniques. And this is the completion picture showing that the stent has sealed off the bleeding. So I think this is a very good example of when you put specialists that have similar but distinct skill sets together, you create an environment, or we create an environment where we can create, innovate, and invent new techniques and new technology.
Great, thank you, Mark.
So
Mark,
I'm going to give you another reason for why we put the brain and the heart together. There's a huge opportunity for improving our patients' care when it comes to open operations. So earlier I alluded to this slide where results with open heart surgery have gotten quite good. The problem nowadays is that patients after open heart surgery can have issues with their brain function. So we've gotten good at fixing the heart, but admittedly, we're not great at protecting the brain. So we designed a randomized trial in aortic surgery at St. Michael's Hospital. We did this across centers in Canada. This was actually one of the largest randomized trials in aortic surgery ever done, where we teamed up with our colleagues on the neuro side, and we looked at differential strategies to protect the brain during surgery for the aorta. So there's a huge connection between the aorta, which lies here next to the heart, and the first few vessels that come off feed blood to the brain. So there's almost a direct connection between what we do on the heart and the aorta and the brain. And instead of focusing on all those endpoints of mortality and heart attack and stuff like that, which we know are already quite low, we actually focused on what was the impact on the brain, on neurocognitive function, and other more subtle elements to look at brain protection and brain injury. And what we actually found, which was quite sobering, is that almost a third of patients after aortic surgery had some form of subclinical injury to the brain. So we actually did MRI scans of patients' brains before and after aortic surgery. And these are MRI pictures of patients' brains from the study. And these little white lesions on a diffusion weighted MRI show that patients are actually getting injury to the brain, even though their clinical stroke rate is quite low. And we show that here. There was no difference in the two strategies we used. So the point I'm trying to make is that by working closely with our brain colleagues, ultimately the goal of brain operations and treatment of brain pathology, endovascular, aneurysm repair, stroke treatment, and to be honest, the treatment of cardiac problems, whether it's a structural heart problem or an aortic problem, at the end of the day, we are now focusing on patients' brain health. We are getting very good at getting patients in and out of the hospital with low morbidity and mortality with regards to survival and cardiac function. The next frontier is to organize our systems of care to preserve what makes us who we are, which is to preserve brain function. And by working with the neuroradiologists, the neurosurgeons, I think we're creating a center that is putting now at the forefront brain health as our ultimate goal of all of these operations.
Okay, thank you, Mark.
I just have a few more slides.
Time.
I know we're getting
I know,
close to the end here.
Time for some questions.
Here is where we're moving to. So this is the Peter Gilligan Tower. The construction, as Dr. Rothstein alluded to, has been completed. And here is the new operative wing of the Peter Gilligan Tower. This will allow us to move the cardiac ORs and the neuro ORs into these really phenomenal new large spaces, all of which will have the potential for image-guided, minimally invasive surgery. So we're now moving from the current state, which I showed you early in the presentation, towards the future state, which is the new tower, where cardiac surgery, neurosurgery, vascular surgery are all brought into one space, geolocated, to create an environment to continue to build upon the things that we've been doing already. So what does the future or present brain and heart specialist look like? Well, it's not just a surgeon who has training in cardiac and neurological disease and standard surgical skills. It's somebody who also possesses interventional catheter-based skills, minimally invasive surgical skills, somebody who understands the value and the need for an expertise in advanced imaging, and also who can work with Dr. Mohammed Mandami and the growing data analytic and data scientists to combine all of the data that we capture from these procedures and operations to help use AI to improve on the things that we're already doing. So what's the leap into the future? What does healthcare 3.0 look like? Well, it looks like all of those people working under one roof. And some of the things, I'm going to leave you with some of the things that we're working on, which is really why we need continued funding from donors like yourselves to allow us to plow forward and take that giant Star Trek leap into the future. So we're in the current process of trying to recruit a neurosurgeon over here sitting at a console, who will help us develop our endovascular, it's a mouthful, telehealth, sort of telerobotic endovascular surgery program. So this is an example of this particular neurosurgeon where he's doing robotic neurointervention. So accessing patients' blood vessels, but using a very sophisticated robot to control the catheters and wires instead of using his or her hands. These catheters can be actually manipulated by sitting at this console. Well, why does that matter? Well, if somebody has a stroke, one of the things that our endovascular neurointerventional group here at St. Michael's Hospital is focused on, and our leaders in, is being able to remove clot out of people's brains. So when you have a stroke, it's typically because a clot has formed in an artery of the brain and the downstream brain does not have sufficient blood flow. You have to get that clot out quickly. So they have catheters and wires that can go into the brain and suck the clot out. But if you live in Thunder Bay or you live in Sudbury and you don't have access to the St. Michael's Hospital suite of endovascular suite and the experts on site, how could you have that done? You can't be transferred in 2 hours, which is really the window to get this done. So what you can do, what this teleremote would allow us to do, is it would allow some of our neurointerventionalists to if somebody could get access to the person's blood vessels, say in Thunder Bay, and establish the robot system, the experts in Toronto can remove the clot in a patient in Thunder Bay. So this is really cutting edge, futuristic stuff. And so really this is kind of just, would be the foundational piece for not just the neuro program, but we would like to develop, we're in the process of developing at St. Michael's Hospital, really creating a global center for remote telerobotic endovascular surgery, whereby these concepts of operating remotely on a person using minimally invasive wire-based skills could be done not just by a neurointerventionalist, but a cardiac interventionalist. So very excited about the future potential of this. This is only possible in the kind of environment we're trying to create. And I'll leave you with one last futuristic looking thing. We're also in the process of trying to acquire a specialized tool called the Zapex, which will allow the neurosurgeons and the neurointerventionists to treat brain tumors without cutting into the patient's skin. So a patient can go into this machine. This machine can be put anywhere. It doesn't require any special shielding. And it basically allows a targeted treatment of brain tumors, skull-based tumors, and a number of other conditions. And there's only been 2 places in the world that have had this machine installed. And hopefully St. Michael's Hospital will be high on the list to get this going. I'm just going to show you a video of how this works. So again, a very specialized futuristic machine. It's based on gamma knife technology. I'm not an expert in this field. I'd have to defer to my neuro colleagues. But basically, this machine really, it takes a giant leap forward in allowing treatment of a patient's brain tumor without actually cutting into their skull. Some of the old versions of these machines required the patient's head to be put in a fixation device. That's no longer the case. This speeds up the treatment process. It's patient-friendly. It's much more rapid. It has a lot of advantages compared to the old generation or the current generation of non-invasive treatment for patients' brain tumors. I think for the purposes of time, I may just skip over this. But we're really excited about helping support our neuro colleagues in acquiring this equipment and depend on the generosity of our foundation.
Mark, I think it's great. I think if we can just...
At the end of the day, we're going to put together a center that houses, or we are putting together a center that houses the best of neurosurgery, cardiac surgery, neurointervention, neuroendovascular, vascular, interventional cardiology, medical imaging under one roof. And we hope eventually that although we've been bringing these assets together under closer proximity, as I've alluded to in the new OR tower, ultimately we'd like to in the future build an entire center completely dedicated to this sort of new foundational way of treating patients. So at the end of the day, we believe that, everything we do here is to challenge the status quo. Like Apple sort of had this mantra of thinking differently, our mantra is to treat differently. We think we can do this by bringing together the best and most talented people into one de-siloed, patient-friendly or patient-centered space whereby we can not only use technology to its fullest, but we can invent new technology and new techniques, generate new knowledge, and define new practices ultimately for the purposes of restoring brain health and heart health to our patients in the least invasive, least intrusive way possible. So I'm just going to leave you with some advanced imaging that's being worked on locally. And hopefully this has given you some inspiration to consider making a donation to our hospital. So I'd like to thank everybody for their very generous time. I'd like to make a special thanks to Walter and Maria Schroeder, pictured here, for donating $20 million and possibly some future funding to support our programs. Really, they made the they really helped us get the Brain and Heart off the ground. So thank you very much. I'll take some questions if there's time.
Mark gave a riveting, insightful, informative, and extremely enthusiastic. I'll tell you, if there's anybody who's possessed with the spirit to make this center go, it's going to be Mark and the colleagues that he brings along. So a great presentation, enjoyed it, and great that I was able to participate in it.
We're glad you were here.
Thank you.
Excellent. Any questions that anybody has?
How much would that gyroscope, would that Zapex machine cost?
That's a very good question.
2.6 million.
How much?
2.6 million.
Oh.
There we go.
I thought you said 26. 2.6 is a lot better.
2.6 seems like a bargain, doesn't it?
It does.
Wow.
Well,
Amazing.
Thank you all again for joining us. And if advancing excellence, medical ingenuity, and innovation, passionate, compassionate care, as Mark has shown us today, and all of these things matter to you, then I'm sure you'll see why St. Michael's Hospital and this Walter and Maria Brain and Heart Center is truly a great place to throw some support behind. As Mike mentioned at the start of the evening, thanks to tremendous donor support and the hospital's commitment, to date, we've raised $33 million of the $42 million to build the center. So that leaves just $9 million to reach the goal. Big thanks to everybody who's already contributed to this campaign. And to those of you who haven't, if you have questions or would like to add any other thoughts to this conversation, we would be delighted to hear from you and delighted to have another conversation with you. Thank you all for joining with us, and we hope to see you again very soon. Thanks, everybody. Thank you, Mark. Thank you, Ori. Thank you, Mike.
Yeah.